Okay everyone, so I think most people are in here and obviously we're keen to keep to time so we get you to the curry tonight in time. There's been a slight change to the programme now, so this is the specialist thoracic practice, but Calcat's not available today at short notice, so we've had to swap a couple of the lectures around. So I'm going to give my pneumothorax talk that was scheduled for tomorrow, and Mr. Fallow's going to give his talk on diaphragm today, and then Mr. Calcat will give his two talks in the specialist thoracic section tomorrow. So I hope that won't cause any disappointment or confusion. I'm also chairing myself now because I was chairing this session. So my name's Juliet King, I'm a thoracic surgeon at Guy's, for those of you who don't know me. And we've gone from the excitement of the future of AI and robots to one of the more simple and more straightforward aspects of, but one of the more common aspects of benign thoracic practice. So I'm just going to talk to you for 20 minutes on pneumothorax surgery. We've got a busy programme, we'll try and keep to time and we'll have questions at the end if everyone's happy to wait. We've got 15 minutes at the end and then coffee we can run into if we get carried away with enthusiasm. So just to remind you, when we're talking about pneumothorax, what we're talking about is free air in the pleural cavity, which may or may not be associated with an active air leak. And conventionally, we subdivide patients with a pneumothorax into two groups when they are not either iatrogenic due to a biopsy or surgery, or they're non-traumatic, and we call these primary or secondary spontaneous pneumothorax. And we kind of say that the primary pneumothorax patients are ones with normal lungs, and the secondary pneumothorax patients are those with abnormal lungs. But clearly, even anyone who's had a pneumothorax that's happened spontaneously does not, by definition, have entirely normal lungs. So it's a slightly arbitrary definition, and it's really based on outcomes and operative plans, and rather than underlying anatomy. But you need to remember you've got two groups here. You've got young people who are at college, starting work, want to travel, want to do contact sports, and you've got to do an operation that's not going to cause them problems for the rest of their life but be effective. And at the other range, with the secondary pneumothorax patients, you've got elderly, vulnerable people with poor physiological reserve who are very vulnerable to the effects of another pneumothorax. So it's important you get it right as much as possible. So we've got our classical primary pneumothorax patients, you know, tall, skinny, maybe a bit of a pectus, but just for Joel. Making me excited.
Let me add in.
With pretty much normal looking, nice, healthy lungs. This isn't somebody who lives in central London and who may just have a little bulla or something at the apex of the lung that's caused the problem. At the other extreme, you've got patients with diffuse cystic or emphysematous lung disease who may have very little lung parenchyma left. But there's a big overlap and special circumstances and unusual conditions in the middle where surgery might be a bit more of a challenge. So young people who smoke a lot of weed and have got lungs of a 60-year-old, young patients with underlying severe parenchymal lung disease, pneumothorax that happens in pregnancy, catamenial pneumothorax. These are all things that can be more of a challenge to manage. So it's a review course. We're supposed to be evidence-based here. So what's the evidence to support the surgical management of pneumothorax? Well, it's pretty much an evidence-free zone to a greater or lesser extent. And there's some reasons for that. So certainly in the UK, pneumothorax is a medical condition. It's managed by physicians, and we don't even know the patient exists unless they refer them to us. So we have very little influence on the early management of these patients, particularly if they're not in our own hospital. Most of the guidelines are written by chest physicians with input from surgeons and other people, but they're very much the gatekeepers to these patients. And most of the guidelines are really about initial management. Do you put a chest drain in? Do you aspirate? Do you manage a patient with ambulatory care? And if you look at the evidence they're based on, a lot of it's just clinical consensus or poor evidence base. And there's virtually nothing out there about how to manage these complex patients who might have extenuating circumstances or things that makes it more difficult. So in the UK, we've got the British Thoracic Society guidelines. These were published beginning of last year as part of a wider guideline on the management of pleural disease. And you can see there's some very well-known high-profile physicians and surgeons in that group who produced these guidelines. I don't expect you to be able to read this from the back, but this is their management protocol. What I will tell you is that nowhere on that page does it say anything about surgery. Not one part of that pathway says do an operation. It's conservative management, ambulatory management, needle aspiration, and they kind of assume that they will always successfully manage the pneumothorax and that will be the end of the episode, which clearly isn't always the case. They based their guidelines on a few key questions that they thought were most important. So these are the sort of things they thought they should be asking when they did their review. So, what are the best interventions compared with an intercostal drain? If patients have had a single episode of pneumothorax, should they be referred for surgery? In patients who've got an ongoing air leak, what should you do about it? And what's the best type of operation for them? So what did they decide? Surgery can be considered if it's important to the patient to avoid having another pneumothorax, or if they're high risk of having another pneumothorax. In adults who've had their first episode, is elective surgery a good plan? No evidence available. Can be considered if it's important to the patient to avoid having another pneumothorax. And in my experience, the desire to have surgery sort of relates to how many chest drains they've had put in and how traumatic that was for them. What's the best approach? Insufficient evidence. Should they have a VATS or an open? VATS appears to have a shorter length of stay and fewer complications than the thoracotomy. Is there anyone in the room that would go straight to a thoracotomy for a first-time pneumothorax patient? So you don't always need evidence to tell you what's common sense and what common practice should be. But it's difficult because, these guidelines are trying to be evidence-based. There are some interesting things they tell us. So length of stay between thoracic surgery and a drain is no difference, but the vast majority of things it's not reported, no evidence, which makes it pretty tricky. More recently, we've had the joint European guidelines, so this is ERS, ESTS. They do actually mention surgery, bottom of their phone, which is good to see. So very bottom is suggests consideration of the VATS in patients, again, who prioritise the avoidance of recurrence. What they do, which I think is really nice, is a sort of patient aid, is give you a visual aid to what the different approaches would do. So you've got observational care, needle aspiration, ambulatory care, chest drain and surgery, and you can compare average length of stay, how many patients this would affect. So you can see for surgery they're saying you're reducing the recurrence rate down to about 6% as opposed to 21%. But if you look right down at the bottom, number of studies this is based on, 1. They also ask questions about what should be the best management, again, when you should intervene with patients, how many pneumothoraces they should have, whether you should use things like valves in patients with secondary pneumothorax. And as you can see on there in the italics, most of the things there's no evidence or no recommendation. So I think the reality is a lot of us know what the indications for surgery are. Clearly, if, like this poor man, you rupture your bully and fill your chest up with blood from a torn adhesion, they pretty much need an operation. Most patients who present like this are very reluctant to have another pneumothorax ever in their life if they've been through the trauma of nearly exsanguinating. So, I think also patients who've had attention would probably be somebody you'd be really keen to avoid from having another episode. Similarly, the patients with secondary pneumothorax who've had significant physiological compromise from it, you would want to have a low threshold for offering them intervention. And I think it's important, some of the guidelines, they say refer secondary pneumothorax if fit, but I think it's the surgeons who'd be deciding if they're fit enough for the surgery, not the physicians often, because obviously they are less familiar with what our anaesthetists can and can't do safely and all the extra things that we can do to get high-risk patients through a difficult operation. Clearly, not all patients do resolve with conservative management, and if they've had a persistent air leak for more than a few days, most people would accept that's an indication for surgery. And there are some people whose professions either require it or would put them at high risk of complications. So what are the principles? Well, this is kind of how I think about these patients. So if you're operating on somebody who's got an active pneumothorax at the time of the surgery, so non-elective, you want to identify where the air leak's coming from and do something to stop it. Obviously, if it's an elective operation, you won't have an active air leak at that time. You also need to think about are there other abnormalities within the lung that may cause recurrence in their own right. And because you can't always be certain where the at-risk lesion is, sometimes you can't see anybody when the lungs collapse, or they've got such diffuse disease that you're not sure you can resect all the abnormal tissue, which is usually the case of secondary pneumothorax. You want to pleurodese the patient by some means so that if something goes pop, the lung doesn't collapse down, or the air leak or the effect of the air leak and the pneumothorax is minimised. I'd say always have a good look at the lung. I wouldn't conventionally ask for a CT scan in a young patient with a primary pneumothorax if it was straightforward, but occasionally you will pick somebody up who's got some underlying parental lung disease, like histiocytosis or something that may not be as obvious on the X-ray. We've got quite a few patients who have something called Burke-Hogg-Dubé in our area, which is another genetic cystic lung disease, which is less extreme than cystic fibrosis and LAM. And on the CT you won't spot it on the X-ray, but obviously you would have to manage them as a secondary rather than a primary pneumothorax. And obviously you want them to stop smoking if that's been a contributing factor, and you need to counsel them about whether they can fly, what activities they can do, whether they get travel insurance if they haven't had a surgical intervention. So, first thing to do, look for the source of the air leak. Beware the apical adhesion that might, I don't know if you can, how well that projects, but in the first one there's a nice juicy adhesion there at the apex with a blood vessel running into it. So I always put the camera in, have a good look at the apex before I even touch the lung, and just make sure I'm not going to pull something off, grabbing the lung to look for bully. Always check the apical segment of the lower lobe as well as the apical segment of the upper lobe. Have a good look round the back, because that's places where you might not see bully very easily, and then remove the abnormal area. If you've got an active pneumothorax and you can't see an obvious source for the air leak, if you can't see a ruptured bully, if there's lots of, classically you may see there's a lot of apical adhesions in the area where you think the air leak might be coming from. You need to decide how hard you're going to look, how safely you're going to be. It always seems like a good idea taking loads of apical adhesions down until you start it, and then you often regret it and it's all a bit of a mess. But you can put some hot wash in the chest and ask anaesthetist not to bang up the lung, but just unclamp the tube, let the lung come up slightly, hold the apex down underneath the water, see if you can see any bubbles coming from anywhere. That might give you an idea of where to look. And if they've got a lot of apical adhesions that are vascular, I clip them, but I don't try to divide them or resect them. I just leave that place in situ to minimise the risk of a vascular injury. Obviously, sometimes patients are more complicated. They can have bad surgical emphysema, they can have severe underlying lung disease, effusions. You can get spontaneous pneumothorax and association with mesothelioma and other malignancies. So have a good look around. Anything that doesn't look like biopsy, send cytology if you're concerned at all. Obviously that will be guided by the age of the patient and what the scan looks like. You then want to do something to stick the lung. So classically I'll do a pleurectomy, often leaving the very top of the apex because the lung's not going to stick there anyway if you've resected the apex. Do a pleurectomy down to the level of the axillary port, and then use a scratch pad or something to abrade the lower areas, the diaphragm, costophrenic recesses. That's the area where you're most likely to get a recurrence, because obviously it sticks less well because the diaphragm is moving. So if people do recur, it tends to be basally for that reason. What you need to be careful of is patients with a bleeding diaphysis. You may need to not do a pleurectomy. Patients who had a pneumothorax in pregnancy can be quite hyperemic and bleed a lot more than you might expect. And obviously you've got baby to think about as well as mum. And if the patient's got a condition that might need transplantation in the future, you need to think about, are you going to do something that will make future surgery more difficult? You've got to balance up the benefit of preventing a pneumothorax with making surgery more complex in the future. This was a very enthusiastic talc pleurodesis. It's more like Mont Blanc than anything else. But obviously some people use talc rather than doing pleurectomy. I don't tend to use talc for primary pneumothorax as a first issue unless the patient's asked for it or there's a reason not to do a pleurectomy. But it's painful, doesn't always work, it can induce ARDS type reactions, and obviously it will only work if the lung can fully reinflate and stick. But some people use talc and that's fine. Wouldn't ever use it in the presence of infection or if there's underlying lymphangitis in the lung, that can cause problems. So these are sort of areas that are still, if not controversial, but still cause a lot of interest and discussion. Every other year we seem to discuss at SETS, should we offer surgery after first episode of pneumothorax or wait till the second episode? So I think these are some of the discussion points to think about managing these patients. So I would say that I'm happy to see any patient who's had even a single episode of pneumothorax if they want to discuss the option of surgery. You have to counsel them carefully, you have to explain that their risk is probably about 30% on the same side, 10% contralateral in your life. Make them aware of what the risks are, make them aware you might be over-treating them, but it's the best chance of reducing the incidence in the near future, and it'll get them travel insurance again and allow them to get on a plane and do stuff. But you have to be very careful. And obviously it's their choice then whether they want to do that or not. I've had some patients who, like the guy with the CT who'd had the spontaneous pneumothorax, he'd got bully on his CT on the other side. He said, I want you to do the other side, even though he's never had a pneumothorax, because he was so scared about the thought of it happening again. And when we operated on him, he did have vascular adhesion on the other side, so it actually could have happened again to him. I always send fluid if I'm worried. If it looks murky, I send it for micro. If it's an older patient, the fluid doesn't look right, I'll always send samples. They've had a hemothorax, so they've got an empyema, they'll probably pleurodese themselves, so less need, I think, for a pleurectomy usually in these patients. They'll often bleed a bit more because of the infection there, so that's something to consider. And I don't think anyone would disagree that VATS is the procedure of choice, and I don't think you need a robot for this surgery, for most of the patients anyway, unless it becomes really cheap. What to do in case of post-op recurrence. So we'll all have had the disappointing patient who think you've done a really good operation, you've done a really good pleurectomy, you've taken away the bully, the lung comes up, and then 6 weeks later they come back with another pneumothorax, and you look in and there isn't an adhesion anywhere. The lung hasn't stuck in any place, and you can see the lines of your pleurectomy. Some people just don't pleurodese themselves, so normally I would then talc rather than trying to do a redo pleurectomy if it hasn't worked the first time. Double check you've not missed any bully. Might have been something you didn't see first time. And I don't think we really know whether bully redevelop in the future. We kind of assume they've been there all the time, and you take them away and that's the end of it, if they're not smoking cannabis or other things, but I'm not sure that is the case always. And I'd only do a thoracotomy if somebody's continuing to have multiple recurrences despite that multiple VATS approaches. The incidence is quoted less than 3% recurrence if you have a thoracotomy, but clearly pain and recovery are much longer for most patients. Final thing, endobronchial valves can be a useful adjunct in patients who really aren't fit for surgery, who've got prolonged air leak. It might just reduce it long enough for you to get the lung up and talc them or do something else, but obviously it increases the risk of infection, so you need to weigh up the risks and benefits for that. Okay, thank you very much.